And this presentation will be shared to ACMI membership and your network. So with that, thank you so much, Koren.
Thank you, Jody. I appreciate the opportunity to come and speak with you guys. I'm going to share my screen a moment, as I have a presentation for you guys. So welcome. As Jody said, I'm a program manager. Many of you probably have heard of TASC, Treatment Alternatives for Safe Communities. They do a lot of case management and treatment services. So the Center for Health and Justice is a branch of TASC. We do more of the technical assistance and more of the research side of things. So that's kind of where the Center for Health and Justice falls in. So I'm going to talk to you guys a little bit about what deflection is, so I can just lay the groundwork of what my project is in Illinois and like what we're trying to accomplish here. So first of all, deflection, a lot of people have heard of criminal justice diversion. When I was a case manager with specialty courts, that was diversion. And deflection is a little bit different from that. There are a lot of similarities, but there are differences. So deflection is much more centered into the community. So that means that we're using services in the community, we're keeping people into the community, and we're getting people when they are still in the community. Criminal justice diversion, that's more centered in the justice system. You're going to have someone from the justice system that's in control of that person's case. You're going to have, they'll have already entered the justice system, or maybe exiting it at that time. So deflection, we're moving people away from the justice system before they've even entered it. So we're trying to get to them earlier. Diversion moves people out of it after they've arrested it or after they've entered it and they've been arrested. With deflection, there is the benefit of having no official arrest record. Unlike diversion, where there is going to be that arrest record with all of those negative consequences that come with that. Deflection is also more behavioral health guided and works in partnership with the justice system. But that means that the focus is on behavioral health services and treatment rather than on the justice system. Diversion, on the other hand, is focused on the justice system. So more focus on that probation officer, parole officer, and then may have that additional behavioral health partnership. So those are kind of the two differences between deflection and diversion. And as you can see on the screen, there's a variety of different terms that deflection can fall under. All of these terms are considered to be deflection. They just all fall under that big umbrella term of deflection. And what it boils down to, whatever you call it, is it's a third option for our first responders. So that's police, fire, EMS to take. Instead of having them either arrest somebody or transport them to the emergency rooms, or taking no action when there's either no arrest to be made or someone refuses to go to the emergency rooms. Instead of leaving, having first responders leave the scene, knowing that they're going to come back probably because they can see that there's something at play, such as substance use or mental health, that they can deflect people into different community services. Deflection, it works in both the crisis and non-crisis approaches. So we have the mobile crisis teams that works kind of in that crisis approach and the crisis intervention teams, but we're really trying to work in that non-crisis time frame before a crisis even occurs. So the easiest way to explain deflection is we're not waiting or needing for any of these events to happen. We're really trying to work earlier on and get to people sooner and prevent them from going into that justice system. And again, talking about people in the community, that it's centered in the community, meeting people where they are while they're still in the community. When they come in contact with these first responders, a lot of times they're still in that community. They are either at their home, at the jobs, somewhere like that. So keeping people in the community and working earlier on. By working earlier on, we can get in contact with more people and get them connected to more services as well. So for those of you who are much more of a visual learner, this is more of the visual representation of what's on the criminal justice system. And this is the sequential intercept map of the justice system. So way over on your left, you see the green in community. The green in any of my slides is going to always be community. And then all the little arrows out are ways out of the justice system. So by offering community-based services, housing, recovery supports, any of those kind of services here, while people are still in the community and before they fully enter the justice system, we're able to safely deflect them, keep them in the community, prevent them from entering the justice system, but also give our first responders an option other than taking no action. So these other bubbles, this is diversion. And we've been doing diversion for quite a few years now, and we've learned a lot of lessons from diversion. Getting people connected to services and treatment, getting them into employment services, getting them housing, all of those kind of things, and doing those wraparound services. By doing that, we can help prevent people from re-entering the justice system and reduce recidivism rates. So we've taken all these lessons that we've learned from diversion, and we've simply just moved it upstream. So we're just taking diversion and we're going earlier upstream. Again, deflection, we're trying to prevent people from entering the justice system. Getting to them earlier and getting them connected to those important services will help prevent them from entering that justice system. Right now in the United States, we have this gap that exists, and it's about an average of 6 weeks, give or take, depending on where you are and what services are available in each community, where when someone comes in contact with a first responder, if they want to get treatment right at that point, it takes about 6 weeks to get to treatment. So what we're doing with deflection is our goal is to try and close this gap. Now, we know that it's not going to be within immediately, that treatment is not going to be coming on scene to the first responders to get somebody into services. We absolutely know that. But the goal is to start working on closing that gap. And during that time, while we're working on closing that gap, we're working to provide case management for citizens. We're collaborating on a systems level stage where all of the systems in the community are working together and collaborating with each other, and we're gathering different metrics to help us make decisions in the future. So with this gap, we have our first responders that will do their 1/10 of the work. And the treatment service providers doing 9/10 of the work. And the reason for that is the 1/10 for the first responders is leveraging their contacts. That's what they're good at. They come in contact with a lot of people earlier on than a lot of service providers see them. They have those contacts that we can leverage. They're also not social workers. They don't have the time or the ability to help stay with somebody to make sure that they're getting in contact with a treatment provider or going to find housing, whatever that may be. So the first responders, we're just asking them to let us leverage their contacts, figure out who they're coming in contact with that would benefit from getting into services. But we also need the system, or the service providers. Without service providers and doing those interventions of that treatment, that housing, that education, whatever it may be, without those interventions, we're not going to have any changes from those that are coming in contact with law enforcement and first responders. So we need to have those interventions, and that's a huge important thing with deflection as well. Another huge thing that needs to happen in deflection is what we call relentless engagement. So when a first responder comes in contact with somebody, if they decide at that point that they want to get connected to services, in the meantime, since there is a lot of time to wait, we need someone who's there, continuing to engage that person, helping them figure out what do we need, what do they need, what services do they want to get into? Maybe they need help with paperwork, maybe they need some transportation to get to these services, Maybe they just need a service or a support group, whatever it is, this relentless engagement. Even if people are kind of on the edge of like, I don't really know if I want services and I don't know if I want your help. During that relentless engagement, a lot of rapport can be built and trust can be built that when those people are ready for services, they have someone that they can reach out to get connected to services. And here in Illinois, with this project that I work on, we have a special workforce that does this relentless engagement, and that's called deflection specialists. So these deflection specialists, when they get a referral in from a first responder, they're contacting them. They're seeing, hey, how can I help you? What can I do for you? What do you need? Maybe it's just a hot meal that today they just need a meal. They're hungry. They don't want to think about treatment right now because they're hungry. So the deflection specialist helps them get a meal. And then at the next contact, maybe it's, hey, they need some clothes. Okay, so we get them some clothes. And continuing to build that rapport until they're ready for treatment. Or maybe they don't even need or want treatment. We've had some that just need an ID in order to be able to get a job because they haven't had an ID. So they need an ID to get a job. So even something simple, that's where the deflection specialist can help. And they do that relentless engagement. So, and without this relentless engagement, deflection is less likely to happen. So deflection is kind of a numbers game. And for those of you that like to see the data and the numbers, this is going to be for you. So for post-adjudication, there's about 6.9 million people that we would have contact with that we could get into different services and be able to assist. So pre-adjudication, before their sentence and everything, go to jail, about 10 million. So we're seeing an increase in numbers. With deflection, where we're working earlier on and more upstream, we can reach 61.5 million people. We leverage those contacts by first responders. That's 61.5 million people that we could get in contact with, and we could start servicing earlier on before things get worse. So kind of how does deflection work? This is kind of a little visual of deflection, where everything is centered in that community. Everything's centered in the community. You have your first responders down there in the blue, on the bottom in the justice system, and there's 6 different pathways to deflection. And the goal is to try to get as many people to treatment and services as possible. And with communities, by doing more pathways, we can get to more people because each pathway services a different population and a different type of people and different type of contact. And I'll go over these in a little bit more depth in this next slide. So the first pathway is self-referral. This is where someone can walk into a police department, fire station, library, wherever it might be, and say, hey, I have a substance use problem or mental health problem, and I would like to get into services. And without being arrested, even if they have substances or paraphernalia on them, they can get rid of that and they can get connected into treatment. The next one is active outreach. These are a lot like the homeless outreach teams, where teams of specialists will go to areas in the community where either there's the the unhoused population, they might know it as an active use area, something like that, where they can go and get connections with people that in that manner that might need assistance. Naloxone Plus. So this is after an overdose has occurred, where a team goes out. Usually it's a peer and a police officer that goes to the home within 72 hours and makes a connection to the person that overdosed, provides them naloxone, and also gives them the opportunity to get into treatment and other services. The officer first responder referral, that's the common pathway that we've been using for our sites here in Illinois. That's when a police officer or first responder is doing their daily work. They come across somebody who there aren't any charges present. There's been no crime that's been committed, but they can see that could benefit from getting connected to different services. they make that referral. And that's where that comes from. The officer intervention pathway, that's when there are charges present. So some sites can, if officers have low-level charges present, maybe it is low-level possession charges, they can hold those in abeyance if someone chooses to go to treatment in that time. And then if they decide not to go to treatment later on, those charges will then be brought back up. And the sixth pathway is community response. This actually has no first responders at all. This is all unarmed civilians that respond to calls for service. Usually they're very low-level calls. They're screened to make sure that they're safe calls, that there's no harm that's going to happen. That having community responders go to mental health calls or those in crisis actually can help better and prevent escalation of calls for service. So I don't know. Okay, so why do deflection? There's a variety of different reasons, and everybody that's involved in deflection has different reasons to do that. Hopefully you see something on here that would resonate with you. For me, when I was a police officer, I remember going to calls for service where it was domestic disputes. So it was verbal only. There was no charges present. A lot of times one of the people were either drunk or high, where they were verbally arguing with each other. And it would be a regular every weekend type of thing where we would be always going back to the house. And then while you're sitting there listening to these people argue and trying to figure out how to help resolve the issue quickly, you're hearing calls for service from your other officers go off. Whether that be, an armed robbery in progress, where that's a much more high-risk call that you want to go help your officers. So for me, it was if we could help these lower level calls and help prevent from doing these lower level calls, we could help our other officers with the higher level calls. So for me, that was why I got into this field. So Illinois has been, is doing this statewide. This is going to be statewide. And Illinois has a variety of different reasons for doing it. And these are some of those reasons. This project actually started back in, I think, 2018, 2019, when Director Kelly from ISP approached DHS and talked that when their drug task forces would do search warrants, they would come in contact with people during those search warrants that weren't the subject of investigation, but were very obviously struggling with either substance use or mental health issues. And they wanted a way to help them. So this was their way. This is one of the solutions as to how to help them. And with that, this program then is able to be expanded to all police departments and first responders in Illinois. So the goals of our Illinois deflection initiatives is to develop and implement pre-arrest diversion deflection programs in all 102 counties here in Illinois. And that is a process that takes a while and is a process because each community is unique in their own problems or challenges that they have in the community. Some communities here in Illinois have more of a problem with meth versus opioids. And it also depends on the community or on the resources each community has. So in each community, we are able to give dedicated time and attention to each one to make sure that they develop a plan and have a program that is set up for success in their unique communities. And with these programs, we're hoping to enhance the health and welfare of every community here in Illinois. So, concept of operation. You've heard me talk about time that it takes to complete these. And this project is not just by CHJ. Our funders and coordinators are the Department of Human Services. We're funded through the cannabis tax. So they fund us and they fund the deflection specialists as well. We have TASC CHJ, so that's me and my team. Carrie Deacon, my senior director, is on today as well. We do the training and technical assistance. So we help the teams develop and implement their action plans and get the sites started, and then can help afterwards if they either want to expand some things that they're doing, if they want to do a new pathway, whatever it might be. We also have ICJA, so the Illinois Criminal Justice Information Authority. They are researchers, so they not only evaluate CHJ and how we do our process, they also evaluate the programs after they're up and running. We also have the Illinois State Police. That's where at least some of the referrals come from. At minimum, we have them on board to be part of the initiatives. And then task operations side, they are the deflection specialists. They provide that warm handoff and case management. And then we always need the service providers that are in each community. So far, this project has started in 2020, I believe it was. So that was before I even started. And of course, it hit we started right with COVID. So these are the different sites right now that we have that are in process of being developed and implemented. The ones south of Sangamon County here, all of those sites are up and fully operational. And so they have been up and fully operational. Sangamon County, Springfield has a site, which is the Springfield Engage, Empower, Deflect. And each site does something a little different. So Springfield works with the unhoused population. The Choices site, they work with substance use and mental health. LEAP, they also work with substance use and mental health as well. The Southern Illinois CERT team, the ones in red, they work with just substance use. We also have a site in East St. Louis that works with victims of violent crime. And then if some of the areas if they already have pretty large deflection initiatives going on that cover the areas, like the ones up here in blue, Sauk Valley Voices of Recovery, we recognize that and we understand that they may already be doing great things. So in order to still include them in this, we will go in and we will help provide more service, like help them either identify gaps that they might have in their program. And then they also still get the deflection specialists as well. So each site will get a team of 5. That's a supervisor and 4 deflection specialists. So when you see these areas, there's about 5 people working in them. The light purple area that's called Choices, they actually split that in 2. So they have 10 people working in that area. And it depends on if there's a larger case, if there's a large amount of referrals. DHS has said that they will provide more deflection staff if needed. So that's and then our Chicago site as well. Our Chicago is focusing on just youth. So that will be our first youth focused site here in Illinois.
And I have a question on
just
because I'm new to this. How do these folks like get together and form a group like McLean, DeWitt, Payette, Vermillion, and then Champagne's not part of it? How does that happen? Do they get themselves?
So initially when this project started, we were focusing on Illinois State Police Drug Task Forces.
Okay.
So these counties are part of Illinois Drug Task Forces. So each county has the option to jump on board with the Illinois State Police. So those that didn't, that's where it looks like we're playing like drunk darts down at the bottom or something. So as we're moving on with this project and continuing to do more and more sites, we're trying to clump them together a little bit more. That's generally how it had been started, was by the Illinois State Police Task Forces. And with Champaign County, there was a lot of conversation with either inviting them into that or not, or having their own initiative. And since they are much more of an urban area with Champaign and everything, and the university in that area, the other counties felt that they would be so different and they didn't want to be overshadowed by Champaign. So they chose not to include Champaign in that one.
That makes sense. Okay, thank you. That clarifies it. Appreciate it.
Yeah. So timing. It says, so runtime, at least on my end, is probably about 12 to 15 months. From complete start, where I start with a site at the way beginning all the way until I've launched them and they're operational and I've completed my TA with them. So these are just kind of some of the things that are included with that. Some of the teams. So if you've heard me talk about different teams, when you were looking at the map, there were different team names, and we have what's called leadership teams. And those leadership teams can be comprised of a lot of different people. First responder, we always have first responders at the table, community health, treatment providers, different service providers, faith organizations, those kind of things. So those are all the people that sit at the table and are making decisions on what these specific programs will look like. So we work in 4 different phases. So our first phase is a lot of preparation work that I do, where I get to do a fun Google search of finding as many treatment providers and service providers in those areas, try to find all their contact information. So I can invite them to a big public meeting called a kickoff. We have a big kickoff meeting that we do, that I give a presentation like this, very similar to this, and invite them into the planning process of their respective communities. And that is the end of phase 1. Phase 2, we go into what's called action planning. So we develop a big action plan that the sites leave with a plan with actionable steps where they can go out and do and actually implement. So action planning, we start with discussing what the problem or challenge is in that unique community, some outcomes that they hope to achieve with the initiative, and then strategies to achieve those and action steps. This takes all in total about 6 days. We work in 2 3-day sessions. So it is a pretty lengthy planning process. And during that time, we have ICJ evaluators at the table during all of these as well. After action planning, we get to go into what's probably the least fun stage for my teams, and that is implementation. That's because that's when all of the hard work gets done. So during the action planning, they talked about all these fun action steps. Now they get to go do all these action steps. And so this is where a lot of the work gets done outside of meetings, where the teams are going out into their respective communities. They're talking about this initiative. They're leveraging more contacts and trying to invite more people to the team until we get to a certain point where most of their plan has been implemented. So implementation, we usually meet about every 2 weeks for an hour and a half. It's done in usually hybrid format. Most teams have chosen hybrid because of the fact that many of these are everybody's coming from such a wide area for travel. For a lot of people, hybrid has been beneficial. And that lasts about 6+ months, depending on how fast the team works. And then after they've fully implemented it, they go to operational. They become operational. That is when they go live and they start taking referrals for services. They do a big launch event where they do like a training event and let the community know that this is going live. And CHJ continues to provide technical assistance for them for the first 90 days, making sure that they have a smooth transition, going from kind of the leadership that I've brought them through to their own leadership as we step away from leading these meetings and continuing to plan everything for them. We also do provide training for our sites. If they want specific trainings, we can come in at any time to help them with training. These are just a list of some of the trainings that we've done before. For Springfield, we had a specific training on the unhoused that we did at their kickoff event or their launch event as well. So your role as part of the 708 board. And I know, Jody, you invited me here because you thought we would do great collaborating with this. And for those of you, if we are in your community already and you're interested in joining your respective initiatives, please let me know. If we haven't been in your area and we're coming, these are some of the ways that you guys can be involved. If you want to be on the leadership team, you want to be at the planning process, you want to sit there, you want to help guide how this initiative works, what pathway they're going to take, what community, what population they'll serve, you're more than welcome to do that. We encourage that. What you can also be is we have what's called referral partners. So those that know about the initiative don't have time to sit at all the planning process, but are willing to take referrals from the deflection specialists for their organization, and are willing to give us the support. Or if you can't even do that, just spreading the word about the initiative. Or if you're not a service provider, spreading the word about the initiative is helpful. You do not have to be a service provider to be at the table. You can be just a community member. We encourage people, especially people with lived experience, to be at the table. So anybody can be involved in this. So you can be one of these, you can do one of these, you can do all three of these, whatever you might want to do. You can be however you want to be involved, either how little or how much you want to be involved. We absolutely are accepting of that and encourage any involvement. So that's the end of my slideshow. So does anybody have questions?
I do have a question.
Yes.
If I could ask. So I love your role as a 708 board. I'm wondering, since we didn't have all of the participants on here today and all of our membership, if perhaps we could have maybe a document that outlines similar to that slide where it's, your role, how you can become involved, and then also like where you're located and like what's coming down the pike, like these are the ones that we're looking at. So it may not be there already, but maybe it's coming down, just to be prepared to inform them in case they don't know. Would that be something that, like a flyer I could include in our newsletter, something like that?
Okay. Yes, I can send you the slides in a PDF format. So you can also mail that out or email that to everybody. And I can look and find like a flyer or something that we're doing of like our upcoming sites and where we are right now.
That'd be great. I appreciate it. Thank you.
Yeah, absolutely.
I have a question, if I may. First of all, thanks for a great overview. That was kind of impressive amount of organization and detail packed in that presentation, and certainly exciting possibilities. I'm a member of the Oak Park 708 board, and I'm interested in, based on your experience thus far, where do you see the attrition in the sort of process from identification of a need to active engagement in treatment or follow-up? So do you have a sense now of where the big points of attrition are?
Yeah, so in Illinois has been following pretty much what the national average is, that of the referrals, about 30% of referrals go into services. Each of our sites are different. I know our Springfield site last month had actually 100% of people going to services. But that's because they also serve the unhoused population. So it's a little bit of a different population that they serve. And so we're sitting right about the average of about 30%.
And is that pretty much the same, whether the services are housing, employment, mental health services, substance abuse, et cetera?
Yeah, all of the referrals, because deflection is voluntary, they're not mandated to go into services. So it's been a mix of different services. Not everybody has been wanting housing or treatment. A lot of people will just want other things, but our biggest ones have been housing, employment. I'm trying to remember the stats from our ICG evaluators, but I know housing and treatment have been some of our biggest ones.
Great, that's helpful. Thanks.
Yeah.
Any other questions from our members here today? Well, and for those that aren't live here, if we have follow-up questions, they can reach out to me, and then if it's okay, I would just forward it on
Yeah.
to you. But this has been an
Absolutely.
informative presentation. I appreciate it. And, you know, the layout visually, it really helps to see it. So I appreciate that as well. So thank you for all of the information. And I will be sending this out to our members as well as, you know, the House 708 boards can get involved if there's one in their community or one that's coming up. So
Yeah, absolutely.
can't say thanks enough. So thank you. It was great.
Thanks for having me. I appreciate it.
Okay. Well, we'll see you guys next time at our next professional development webinar. Bye-bye. Have a great afternoon.